Good afternoon, everyone. I'm Dean Eileen Sullivan Marks, the proud dean of the NYU Rory Myers College of Nursing, and welcome to our 27th annual Estelle Osborne Legacy Award ceremony and seminar and activity. So I'm so thrilled to see you here. As you know, for the last several years, we've been hosting a lecture prior to the award ceremony. And thank you all for coming to that today, because they have been very exciting, and we're thrilled to have Dr. Rueben Warren with us today. So first I want to talk about a little bit about why Estelle Osborne and why we do it this time of year. So Estelle Osborne was the first African-American faculty at NYU, and we'll hear more about her later. But also because this is Black History Month, we've been running a series of seminars, a series of talks on inclusivity, diversity, belonging, and you'll hear more about that as we go later into the session this afternoon. But in that honor, we have Dr. Rueben Warren today to greet us and make remarks. I also want to thank a number of our whole board of advisors who support this effort for us and to have our speakers and for the work that they're doing with us. And several of them are here with us right now, and more will probably join us today. But we have our board chair, Dr. Kimberly Glassman, an alum as well, and as well Dr. Catherine Alicia Georges up here, who's the director of nursing at Lehman College and on our board, so thank you for being here, who already knows Dr. Rueben Warren from the days gone by, she says. So thank you all to all the alumni here today, our faculty, our students and staff, and any friends of NYU. So I'm going to ask Dr. Michelle Shedlin, who's a professor at the Rory Myers College of Nursing, to the podium, who will introduce Dr. Rueben Warren. Thank you, Michelle.
Good afternoon and welcome, distinguished guests, friends, and colleagues. On behalf of our Dean, Dr. Eileen Sullivan Marks, I'm pleased to welcome you to share in the opportunity to hear from a leader in the areas of medicine, religion, and social justice, Dr. Rueben Warren. As I've learned from Dr. Warren, the name Tuskegee engenders many powerful emotions. From national shame to personal anger and commitment to our own efforts to advance social justice, especially in these challenging times. He reminds us that, quote, connecting the past with the present allows us to be more effective agents in shaping our understanding of the forces that will have an impact on our collective future as citizens of this planet. As he states, we honor those who have shown us the way and taught us the strategies for survival, endurance, and growth. To cite Dr. Warren's education and accomplishments would take away all of his time to speak, so I will highlight only a few. Dr. Warren received a BA from San Francisco State, a DDS from Meharry Medical College, an MPH and DRPH from the Harvard School of Public Health, and a Master of Divinity degree from the Interdenominational Theological Center in Atlanta, among other academic accomplishments. He served on the faculties of Meharry, Harvard, the University of Connecticut, the University of Mississippi, and the Morehouse School of Medicine, among many others. Dr. Warren is currently professor of bioethics at Tuskegee University, where he directs the Tuskegee University National Center for Bioethics in Research and Education. His non-academic accomplishments are extraordinary, including service to the NIH, the CDC, the U.S. Public Health Service, APHA, HHS, NCMHD, and many more. His list of honors includes both national and international recognition, including from the countries of Nigeria and Zimbabwe. His many publications cover the areas of dentistry, public health, school-based health, clinical papers, health disparities, the environment, history, spirituality, and of course, ethics. In his latest publication reporting on Black leadership interviews regarding the lack of participation of African Americans in clinical trials, he calls for a paradigm change, one that turns the responsibility for trust to that of trustworthiness, which he will explain to us today, and hopefully a little bit about his very recent trip to Cuba. It is truly an honor and a pleasure to introduce this extraordinary colleague to you and my friend, Rueben Warren.
Good afternoon. What Dr. Shannon didn't mention was that this work that she mentioned, we did it together. And it continues, and I'll mention more about it a little later. I've come this afternoon to share my thoughts about trust, which in my view is the basis for health and meaningful and lasting healthy relationships. It's important to have trust, but I believe there is something that precedes trust, something very, very important that's often overlooked and maybe ignored. But first, let me describe health, since we're all, or at least most of us, are health professionals, or at least call ourselves that. For me, health is a dynamic interplay, a relationship between the physical, social, psychological, and spiritual well-being of the individual and the group, and their interaction with the physical and social environment. It's more than most of us have been taught or maybe even believe. The emphasis is on a dynamic interdependency, both within the individual and among individuals in community. See, I don't believe you can be healthy by yourself. In fact, when you're not feeling good, when I'm not feeling good, I got to tell somebody. I don't feel good, hoping that they can make me feel better. And even if they don't, I feel better because I've told somebody how I feel. And I also believe that trust is foundational to being healthy. Without trust, little else matters. I believe that nurses are the most trusted people among health and healthcare professionals. Physicians usually say what ought to be done, and nurses usually make it happen. I've been around long enough to know that's true. You, the nurse, have, in many instances, established yourselves as trustworthy. When children start school, one of the first people they come to know in the school is who? The school nurse. When there's trouble, they look for who? The school nurse. I've organized school-based health programs in New England and in the South, and the nurse provided the informal leadership. He or she didn't say that they were in charge, but everybody knew. In many faith institutions and faith traditions, the nurse ministry was the safeguard for the parishioners, whether the nurse had any formal training or not. I can remember in church, the person in distress would look for and be relieved when the woman in the white coat, in the white uniform, showed up with a fan and some cool water. and everything was all right. I'm a dentist, and the trust that I try to establish with my patients determine whether they allowed me to complete any procedure. Trust more than skill was the basis for them coming, and more importantly, coming back. But what is trust, and what is it based on? I suggest that trust is based on trustworthiness. Thus, the topic of my comments, the theme that undergirds my presentation, trustworthiness precedes trust, building lasting institutional relationships. Trustworthiness precedes trust, building lasting institutional relationships. I'm very pleased to be here to celebrate Estelle Massey Osborne, the first African-American faculty at your school, as I understand. As you know, she was the first African-American nurse in the U.S. to earn the master's degree. She was born in Texas, 1901, 8 of 11 children. Despite the lack of formal education and working menial jobs, her parents, Hall and Betty Estelle Massey, sent all of their children to college. Nurse Osborne received a teaching certificate from Prairie View A&M University, but decided to go on into nursing after she was nearly killed in a violent incident while teaching in public schools. I also attended Prairie View for 1 year back in the middle 1960s. Even then, the nursing and engineering programs were strong, as they are today. Nurse Osborne joined the first nursing class at Homer G. Phillips Hospital in St. Louis, Missouri, and became the head of nursing there soon after graduating in 1923. I also know about Homer G. Phillips because that was one of the few black hospitals where black medical and dental students and residents completed their externships, internships, and residencies. Many of them stayed in and around St. Louis to practice. 1926-27, Estelle Osborne moved to Kansas City to teach at the School of Nursing. Nurse Osborne attended summer sessions at the Teachers College, Columbia University, and eventually attended as a full-time student and with the aid of a scholarship from the Rosenwald Fund. She received a bachelor's degree in 1930 and a master's degree in nursing education in 1931, becoming the first African-American to do so. She was educational director for Freedman's Hospital, which is now Howard University Hospital in Washington, D.C. In 1934, she worked as a researcher for the Rosenwald Fund, then returned to Homer G. Phillips in St. Louis to become the first black director of nursing. See, I know about the Rosenwald Fund because it was Rosenwald in the 1930s funded the Syphilis Project in selected black counties. When Rosenwald stopped the Syphilis Project due to funding in 1932, the U.S. Public Health Service continued the so-called study, which was the longest non-therapeutic study in the history of the United States. They called it erroneously the Tuskegee syphilis study. All of you have heard about that. And I'll tell you why you shouldn't call it that in a moment. That so-called study was the longest non-therapeutic study in U.S. history. As you know, I currently serve as director of the National Center for Bioethics in Research and Healthcare at Tuskegee University. So I know about that study. The U.S. Public Health Service physicians knew that the people in Tuskegee trusted nurses. So they selected Eunice Rivers, a trusted nurse from Tuskegee to gain inroads into the Tuskegee community and to convince the men to participate in the so-called syphilis study. The explanation they gave was that the men were poor and uneducated, so whatever we did for them was more than what they had. Well, that may be part of the story, part of the reason, but you should know that all of the men were not so-called poor and uneducated. Some of them were farmers, family men. Some had formal education and stable incomes. I know some of the descendant family members. So they were not all poor. The greater attraction was that physicians from the federal government, remember, we in the Deep South, were trusted. And Eunice Rivers, a nurse, had established herself along with black physicians from Tuskegee. They proved themselves to be trustworthy. So it wasn't that the men were uneducated or uninformed. They trusted folks who they thought were trustworthy. The take-home message, I hope you're hearing it, is trustworthiness had been established. When in 1972, after 40 years, the U.S. Public Health Service syphilis study at Tuskegee was exposed, not by physicians, not by scientists, but by the public press. The trust in the federal government, in Tuskegee Institute, and in healthcare delivery was violated. The trust was violated. The myth about the scientific link between knowledge about the syphilis study and willingness of black people to participate in human subject research was challenged and disproven by my friend and colleague, Katz and all. But there was still something that created skepticism, something that said, uh-oh, I don't know. Weatherby, in her work, calls it a site of memory, and I suggest that it was institutional memory, that something just wasn't right. I don't know exactly what it is, but down in my spirit, down in my gut, they knew and said something wasn't right. And you know that still exists today. Something just ain't right. Whether you know the facts or not about the study, something wasn't right. The word of mouth, or whatever you want to call it, caused and still causes pause when it comes to human subject research, and in fact, healthcare delivery for many black people. Moreover, when repeated bioethics and public health ethics violations occur, they reinforce myths about the U.S. Public Health Service syphilis study at Tuskegee. You hear it all the time. When something goes wrong, something goes bad in research or healthcare, what comes up? Tuskegee syphilis study. Site of memory, institutional memory. But you know, myths can be true or false. Just because they're called a myth doesn't mean it's not true. Estelle Massey Osborne is a legend, not only in nursing, but in breaking barriers. I know personally 2 other black nurses who are also barrier breakers. One is the late Dr. Mary Harper, a PhD nurse who is an extraordinary, internationally known expert on issues of aging and mental health. She advised several U.S. presidents on aging and mental health. I could go on all day talking about Dr. Harper. Dr. Harper began her career as a student nurse at Tuskegee Institute. After receiving her BS and MS degree in nursing education from the University of Minnesota, she became director of nursing at Tuskegee VA Hospital. During her long career with the federal government, Dr. Harper worked in hospitals and universities across the country. She received her PhD degree from St. Louis University, published 4 books, and published over 180 articles. Look her up if you don't know who Mary Harper is. But right now, don't act like you don't know. Just shake your head like, oh, I know. She was a giant, humble giant. Another PhD black nurse, Dr. Iris R. Shannon, a 1948 graduate of then School of Nursing, Mary Medical College. Originally from Alabama, Dr. Shannon grew up in Chicago, where she met her first nurse, which was school nurse. Dr. Shannon received her diploma in nursing from Hubbard Hospital at Mary Medical College, BA degree from Fisk University, AM from the University of Chicago, PhD, University of Illinois, Chicago, DPS, an honorary degree from Elmhurst College. I could go on and on and on about Dr. Shannon. Well published also. She was the past president of the American Public Health Association. I bring these 2 women to your attention simply to acknowledge the impact that nurses can have if they choose to. This event is to acknowledge the need for inclusion and diversity, as I'm understanding. Not because it's the right thing to do, and it is, but you really can't achieve health equity, if that's your goal, without including those people who you wish to serve. You can't help me if you don't know me, and you can't really know me unless you have somebody that looks like me, who's been through what I've been through. But I'm not really here to talk about things you already know, because you know what I'm saying. I'm not going to talk about health or health care disparities. You know about them. I'm not going to even talk about the need for more people of color in all health professions. If you want to know more, then read Sullivan's report, Missing in Action, which highlights the need for more black physicians, dentists, and nurses. I'm definitely not going to talk about the worsening health gap between black and non-Hispanic white people in the United States, except to remind you that in 1985, the concept of excess deaths was explored and was adopted in an attempt to explain the mortality gap between these 2 racial groups. Excess deaths is an epidemiological tool that measures unnecessary, preventable, avoidable, age-specific adjusted death rates in the black population if you use a non-Hispanic population as a baseline. Hear me clearly. In 1985, there were 60,000 excess deaths. However, using the same measures in 2005, the 60,000 had increased to 83,000. Spent more money, started more programs, made more commitments, but things got worse. There's an ethical dilemma that was never talked about. My tenure in public health began in the summer of 1969. I've been around for a minute. As a dental student working in the Watts Health Center in Los Angeles, California, that summer I relived many of my growing up experiences as a kid, watching violations in health, education, employment, violation policing in the courts, in almost every walk of life. I didn't know exactly what was going on, but I knew something wasn't right. I didn't need to know the details to know in my gut something wasn't right. It was clear then, as it is now, that those violations bred distrust, and distrust bred more violations, a vicious cycle, a vicious cycle. Yet I'm convinced, nonetheless, that the cycle can be intercepted and trust can be established if we are intentional about our deliberate work and our activities. You have to do it and be committed to doing it. But what is trust and how can it be established? Fundamental question. Theoretically, trust can be defined as measured reliance on character, ability, strengths, or truth of someone or something. The concept of trust has three dimensions: trusting in the fiduciary relationship, trust in as confidence in competence, and lastly, a perception of trustworthiness. Trustworthiness is being able to be relied on to do or provide what is needed or right, deserving of trust. Deserving of trust. Hertzberg, a professor emeritus in philosophy, writes in his book on the attitude of trust, trust is always for something we can rightfully demand of others. I can demand trust. Misplaced trust, accordingly, is not a shortcoming in the part of the trustful person, but of the person in whom trust was placed. You get that? On whom trust was placed. In Trust and Trustworthiness, another book, Harding discusses the synergy between the two terms. According to Harding, the literature on trust rarely mentions trustworthiness. The complexity of trust stems from the lack of trustworthiness. Harding and Hertzberg agree that not considering trustworthiness when describing trust shifts the blame of trustworthiness as a lack of trustful. Both trust and trustworthiness are pivotal in restoring a healthy relationship between African Americans and the research community. Trust and trustworthiness. Professionals who take the time to listen, not to talk, who use plain language, who open themselves to check and challenge, who offer opportunities to be judged about their honesty, their competence, and reliability, are more likely to be trusted. There's a paradigm shift. What we must do to be trusted. To place and refuse trust intelligently, we must first need to judge others' trustworthiness. Before I trust you, I must judge your trustworthiness. Which comes first, trust or trustworthiness? Creating systems where accountability is possible will not make it easier to practice unless the individual expected to trust have a reason to trust the systems in place. So systems that create trust don't work unless the people who are working in them are trustworthy. What comes first, trust or trustworthiness? In a very practical sense, I was not interested in studying the concept of trust because massive, long-term, repeated bioethics violations in human subject research and healthcare continue to happen, particularly for vulnerable populations. No matter how much work we've done on trust, the same things happen again. The same things happen again. There is a long-standing history in the United States and abroad about violations, then regulation. Violation, then regulation. The cycle repeats itself over and over again. Violation, regulation, violation, regulation. I'm sick of regulations. Violation, regulation. It seemed reasonable to interrogate the foundation surrounding trustworthiness as a precursor to trust. Let's look at something different. You know what they say about doing the same thing in the same way and expecting a different result is what? You got it. We were looking for a paradigm shift to better understand the practical ways to establish trustworthiness. The presupposition was that if institutions and individuals were trustworthy, trustworthiness would be more likely. If trustworthiness was demonstrated over time, trust would be more likely to occur. I knew that it worked at the individual level. My dear friend and colleague, Ralph Katz, and I have been working together through thick and thin for many, many years, and I trust Ralph. So I know it works at the individual level. We were looking for ethical principles that could be discerned, that were teachable and generalizable at the individual and institutional level. I was sick of looking for good people. You find a good person, then somebody else takes her or takes him away. So you're without anything. So we needed principles that were both teachable and doable. By the way, trust has metaphysical implications as well, particularly in the Black community. As you heard, I just came back from Cuba. I went there to listen and learn about Cuban culture. See, I believe there's a synergy between culture, ethics, and health. Last year, the National Center for Bioethics at Tuskegee hosted a Robert Wood Johnson-funded national conference entitled Examining the Ethical and Other Implications of a Culture of Health in the Context of the Deep South. Very exciting experience. We were intentional about not inviting clinicians because we didn't want to be confined to a medical model that everybody knows doesn't work. The proceedings are available on our website, so we've got the proceedings for your disposal. I believe that culture precedes ethics and health is one among many outcomes. Culture precedes ethics, and health is one outcome among many of the synergy between the three. I also believe that it's very difficult to separate culture from religion. The late Fidel Castro established a Marxist government during the 1953 to 1959 Cuban Revolution. I learned that while I was there. And that revolution banned all religions. However, Castro later admitted that that was a mistake. And since then, allowed a variety of religious traditions to openly practice, including many of the Afro-Cuban religions. So I learned a lot about that. And Castro said, I made a mistake and fixed it. It was a wonderful experience. As an aside, a colleague fell and dislocated his shoulder and had an opportunity to go to the hospital. He said it was the greatest experience he's ever had, being in the hospital. Say the doctors were wonderful, the nurses were wonderful. The equipment was bad, but it didn't matter. It didn't matter. So I didn't go to find out about the health system intentionally, but found out about it anyway. Metaphysically, for many, trust is faith, which is a life-transforming vertical relationship with something beyond, be it the notion of God, spirit, or the ancestor, whatever you feel comfortable with. Biblically, faith is what our hopes are made of, and evidence of what we cannot see. Some of y'all know about that. It's Hebrew 11:1. That sounds a lot like health in many ways. what our hopes are made of, and evidence of what we cannot see. How do you know? How do you feel? How do you see health? How do you do it? Somebody tells you you're healthy, and are you? Or somebody tells you you're sick, and are you? Fuzzy, fuzzy notion that we need to work much harder to better understand. Metaphysically, faith may also be horizontal in that it represents a consistent devotion to others. I have faith in you, which is unconditional trust. Unconditional trust. Well, our research project focused on trying to better understand how to enhance African American participation in clinical trials and other human subject research. We were intentional in our wording, not to say increasing participation or limiting our efforts to clinical trials, although that's really what we did. It was beyond our control that we didn't do more yet, but we're gonna finish the project. The goal was to complete a multi-phase research project to improve the health of the Black population by enhancing Black participation in research at all levels, from historically Black college and university participation to principal, investigator, and other scientists in leadership roles, to fully and completely engaging community in the research enterprise by involving the Black population using principles of community-based participatory research. Our work was limited to interviewing 34 African Americans who occupy roles in 3 gatekeeper leadership groups. Hear me now. 3 groups: education and research, education and health, civic society, and faith leadership. 3 groups: education and health, civic society, and faith leadership. The research team included Dr. Shannon, who was also a trusted and dear friend, and Dr. Ernest Elamamensa from the Morehouse School of Medicine, and of course me. The research was funded by Eli Lilly and Company. Among our findings, most relevant to my topic, we found there are differences, yet affirming an agreement around themes of trust and trustworthiness. Here's what we found. Both trust and trustworthiness are pivotal in restoring communication and collaboration between African Americans and the research community. Numerous themes emerge from the leadership interviews and the literature related to these key concepts. Trust, for example. Trusting the environment is different from trusting the individual. Trust is a personal interaction. Trust means verifying. Trust is a personal interaction. Trust means verifying. Came up again. Trustworthiness is the demonstration of trust. Trust is ongoing interaction, an ongoing issue. Transparency is needed to build trust. What do they say about trustworthiness? Goes to the character of the person or institution, relates to the integrity of people and institutions that enter relationships, means you are reliable, assures protection, validates what you are doing on an ongoing basis, utilizes other disciplines that have been validated and as worthy professions, means you have received confidence. Trust means that you are giving the confidence in a person or institution, a characteristic of the system. Are we worthy of trust? The different leadership perspectives on these issues also illustrate the continuing prioritization of trust and trustworthiness across constituencies and across time. One of the interviewees said, health professions really have the greatest priority to be trustworthy. Not to ask for trust, but to be trustworthy. Another said, and I'll paraphrase his comments, a trusted researcher can lose his or her trustworthiness if they are working in an institution that is not trustworthy. So be careful where you work. Can lose their trustworthiness if they're working in an institution that's not trustworthy. To that I ask, within the historical and current context, are you and your institution trustworthy? If so, by what criteria do you measure your trustworthiness? And who trusts you? Equally as important is the trust that some of you have worked hard to achieve, lost if your institution is not trustworthy. They can blow your whole program if you're not careful. I've learned since being at Tuskegee that I was extended the olive branch of trust after years of demonstrating my trustworthiness. When I first got there, they didn't hardly speak, and I didn't do anything, but they just said hello. And if somebody just says hello in the morning, and good afternoon in the afternoon, and good evening in the evening, and that's all, be thoughtful. I had to earn their trustworthiness, their trust, by being trustworthy. I work with the folks who working hard and long years to clarify the legacy of their fathers, their grandfathers, their uncles, their aunts, and some their brothers. And my trustworthiness is an awesome responsibility. It gets challenged all the time. Folk call and want to talk to me because I'm at Tuskegee, want to come and have a conversation with me because I'm at Tuskegee. One university, to remain unknown, is doing some work on xenotransplantology. Know what that is? Look it up. Using pig organs. And wanted to come to talk to me at Tuskegee about using a research project that obviously they wanted to include black folk about xenotransplantology. I told them, don't come. Say, I'll come to your university and talk about it. You ain't coming to Tuskegee. Never heard from them again. So the responsibility is awesome. I can do much of what I do because I'm at Tuskegee. I'm not confused about that. So we treasure the name Tuskegee. It's much more than the U.S. Public Health Service syphilis study. The responsibility is awesome. Well, my take-home message is for you to stop asking folk to trust you. Just stop saying it. Because if I have to ask you to trust me, something's wrong. Spend your time proving yourself trustworthy, and trust will come. And it takes time. There's some nurses at Tuskegee who are involved in the U.S. Public Health Syphilis study at Tuskegee. I know who they are, and I know they know who they are. But I haven't asked them a word. When they're ready to tell me, they'll tell me. Until then, I'm going to act like I don't know, and they're going to act like I don't know. But I know. And I speak unapologetically about my lived experience as an African American, as a black person in the United States. My lived experience as an African American is different than many of you, even those black people who were not born here. While we both are of African descent, our lived experiences are similar but different. We are the other. We are the other. And I'm always introduced to the other. And that's a good thing, because if you don't introduce me, I'm going to find the other anyway. And it may not be physically, it may be a head nod or an eye contact, but we always know the other. And that's okay. That's a sense of trustworthiness that can be violated if we're not careful. Trust has an historical context. You see, my ancestors helped build this place you call America. I call it the United States because I know there are several Americas. It's insulting to suggest that this is the only one. And I'm not clear what an American is anyway. I'm unclear. But I am a citizen of the United States, very proudly. But I say to you, as Langston Hughes, the phenomenal black Harlem Renaissance poet, wrote, I too sing America. I am the darker brother. They send me to eat in the kitchen when company comes, but I laugh and eat well and grow strong. Tomorrow I'll be at the table when company comes. Nobody will say to me then, eat in the kitchen. Besides, they'll see how beautiful I am and be ashamed. I too am American, he writes. These are the best of times and the worst of times. And you all have to frame it in a way that fits you. For me, it requires us to decide what we're going to do and do it, not just talk about it. I'm sick of hearing folk complaining about these times, the best of times and the worst of times. Since my journey to Tuskegee, I embraced very proudly the notion of bioethics, which has three principles: autonomy, benevolence, and justice. I've grown to know that that's not enough, as laudable as those principles are. I've had to combine autonomy with community engagement. That's an important component. I've had to add to benevolence, beneficence, not what your intentions are, but what you're going to do. And justice and social justice have two different implications. Community engagement, beneficence, and social justice is what is now considered public health ethics. Important difference, not one or the other, but both and. Don't get the two confused. At Tuskegee, at the National Center for Bioethics and Research in Healthcare, we have a symbol. It's the Sankofa bird. And for those of you who don't know the Sankofa bird, it's an African symbol, a bird that is looking back and moving forward with an egg in its mouth. And it simply means that we have to consider and know the past in order to move forward to the future. If we don't, we'll repeat the old mistakes. Our motto at the center is, I am because you are. Therefore, you are because I am. I can't do anything without you. I may leave you behind sometimes, but I can't go forward without you. This is the end of Black History Month. And you know, you really can't go through the month without repeating something, quoting something from MLK. You know, and everybody ought to know at least one something from Martin Luther King. And And being in New York, you all know something about Malcolm X too, but I'm not going to go there. The king said that I can't be all that I can be. I can't be all that I should be until you are all that you can be. So it's impossible for me to reach my greatest goal without you reaching your greatest goal. Impossible. I can go and I can do, but I can't be my best self without you being your best self. So as I reviewed Nurse Osborne and her wonderful accomplishment, as I've met some of the honorees, what I want you to know is that there are Nurse Osborne everywhere looking at you. You don't have to look for them, they're looking at you. I ask you to look back, and you'll find them. They're all around. They're all around, they're everywhere all the time. I appreciate the conversation. I look forward to talking with you more. Thank you very much. Now, some of you may have some questions, comments, thoughts about something I've said, and please share them. I don't have to be right, I just want to be heard. If not,
good afternoon. I enjoyed your presentation, your
Thank you.
speech, your information. I was curious to find out, well, maybe I shouldn't ask why, but the nurses you said are still at Tuskegee who participated in the syphilis study. That to me, I don't know what to say. I just wanted to know, why are they there?
why are they there? Because as with me, they love Tuskegee. The notion was that Tuskegee, historically, Tuskegee was among the first black hospitals, and it was on Tuskegee's campus, or regional hospital. And so if you're trying to start a study to engage, to include black people in the rural South, where would you go? To Tuskegee. So that's how it became the Tuskegee syphilis study. Before the syphilis study, John A. Andrews Hospital was there treating as a regional hospital. Before the syphilis study, black students, medical students, dental students from Meharry rotated there because we couldn't use the hospitals in Nashville. Phenomenal place. The Tuskegee VA hospital was constructed for black veterans because black veterans couldn't use other hospitals. Tuskegee gave them the land if they would, the government, federal government, would allow black leadership. That was the deal they cut. So Tuskegee was a very proud place, and the syphilis study was a blimp in the history of Tuskegee. Everybody knows or should know Booker T. Washington. Everybody knows or should know George Washington Carver. Everybody knows or should know Ralph Ellison. Everybody knows or should know the Tuskegee Airmen. I could go on and on and on about Tuskegee. The syphilis study was a blip in its history, and they called it the syphilis study erroneously to attract folk to it. So the nurses are there and very proud. We just got a new dean of the School of Nursing, phenomenal scholar, was full professor, tenured professor at several universities, decided to come home to Tuskegee. So I don't know, if you're ever on that campus, it's a spiritual grounding, and you'll never forget it.
Dr. Warren, excellent. Excellent. I knew you could always do this. You know, you haven't changed over the years. You just got better. One of the concerns I have is how do we help people to build trustworthiness? You know, as academicians, how do we get, what do we do? How do we begin to help our folks who will be providing services to vulnerable populations and to anybody to begin to build this trustworthiness?
Well, I don't know, but I tell you what we decided to start is to ask them. And our multi-phase project was first to ask leadership, what do you think there's the difference between trust and trustworthiness? We are going on to ask their constituencies, what do you think the difference is? First, you have to recognize the difference, and then what are the ingredients to build trustworthiness? I don't know, but we're going to find out. But the paradigm shift is most important, is to stop talking about trust. Start talking about trustworthiness. Different conversation. The responsibility is shifted. The opportunity is shifted. But we don't want to talk about it. As we review the literature, a few articles were published on trustworthiness. So the notion is, how do you build trustworthiness? But I do know one thing is time. That much we know. You don't start and say, I just met you, now I want you to trust me. Doesn't happen. Ongoing, repeated. Dr. Katz and I have been working together for more than 40 years. And we got it. And we don't even have to agree. It doesn't even matter. And we're stuck with it. Even when we disagree, it works. He spent part of his sabbatical at Tuskegee. Last year this year we had a colleague, a colleague from England, spent 6 months, 3 months of her sabbatical at Tuskegee. Folks come. Many folks have come. I stopped letting them come, to be honest. They come and publish a book on the syphilis study. You got to be there to really understand it. It took me some time.
Challenged us not to say the Tuskegee study. What do you recommend we call it?
It's long, but it's true. The United States Public Health Service syphilis study at Tuskegee. Because the epicenter was the U.S. Public Health Service. So when you say that, it reframes, you mean the U.S. Public Health Service? The federal government? So it's a paradigm shift, and it shifts the thinking. It's long, but it shifts the thinking. It was originally the Tuskegee study of untreated syphilis in the Negro male in Alabama. Now think about that. Untreated syphilis, which means they never intended to treat it. Negro male targeted population in Macon County. So the change in language, a colleague told me that critical thinking starts with a change in language, critical language. How do you frame what you want to say? Frame it, U.S. Public Health Service, syphilis study at Tuskegee. It's long, but it has meaning. Yes, ma'am.
I wanted to know, I don't know if I heard the microphone. I recently met a group of minority doctors who were given a full scholarship to train in the medical schools in Cuba. And they thought it was the most wonderful experience that they've ever experienced. What was your feeling about that, or were you aware of that?
I was quite aware. Matter of fact, a friend of mine just completed his master's in public health at the University of Liverpool. And his thesis was to look at a group of U.S. students who went to Cuba and to medical school, then came back to the U.S. to do the residencies, and he wanted to see what they were doing. And they were doing, according to his thesis, were doing phenomenal things. So all the folks that many of the folks that I've met who did their medical school in Cuba had a good experience. So I have a lot of respect for that. And then ironically, or I'm not sure if it's ironic or not, many of those students would not have gotten into medical school here. Yeah. So they are, as many of my colleagues, including me from Meharry, say that Meharry takes students that nobody wants, and in 4 years gives them doctors that everybody wants.
And they said there's no cost to them.
No cost, that's right. And the colleague who hurt himself, he showed, I said, what did they charge? He said, nothing. And he was shocked. He said, it was, I didn't go there for that, but I got an opportunity to talk to somebody who actually experienced the Sir.
Your title and your talk together got me to continue thinking about this enduring story of the syphilis study at Tuskegee, run by the government, and the fascination with it that has taken anyone who hears it by surprise. And it occurred to me during your talk that maybe one of the elements that could be isolated in the fascination with the story is the unexpected fact that Nurse Rivers is questioned for her trustworthiness. And it speaks to what you opened with about the trust that people have in nursing and healthcare. That it is the group that has isolated itself almost from all the others as the most trustworthy of the groups, just broadly speaking. And that may be a large part of the utter shock of it. I'm from the government, I'm here to help you is a joke because it plays off people's expectation about trustworthiness. But not that I'm here from nursing and I'm here to help you. That would be, yes, of course. And it may be that that is a thread that runs through the utter fascination with this. On the other hand, I will tell you, after years of thinking about Nurse Rivers and her activities and the balance of factors she had to weigh, both from being an individual, it's like peeling an onion, being an individual with aspirations, her father's aspirations for her, making the achievement of getting through a nursing school at about this era, and then being offered this, pulled out of all other people in the area to be tapped by the government because she stood out to the local folks who are now in charge because of that agreement. It's an amazing phenomena that you think about, and yet there's another side to her life. If you actually count up the number of roundups that were done, there were 13 published papers, and each one was about a roundup over the 40 years. Those roundups lasted 3 months, 4 months total, 2 or 3 of which was gathering up and getting ready for it, then a month on the ground getting the men to the examining team from Washington. But for 40 years, she worked in that town. And she was the public health nurse. Nothing to do with the study at all. She served people. She babied them. She took their babies into the world. She took people out of the world. She was their public health nurse. And if you think about it from Nurse Rivers' perspective, 95% of her living life over that 40 years had nothing to do with the study, except it paid her salary to let her be that rarest of rare commodities, a public health nurse serving a large-sized community. And it was the region around Tuskegee as well. So in her daily thinking or yearly thinking, I'm sure the study was a point of pride, but wasn't what she was about. But yet it's all the world knows about her because that's what made the headline. And she was with the ability to be a public health nurse. And that's another balance in her mind of how do I give this up even if I don't see them moving at the pace that I'd like to move on to finally get to the treatment phase that kept being talked about. Very complex life, and she is intellectually the holy grail of how this continued. And it speaks to how do institutions, local, build or not build trustworthiness. Your talk triggers that.
Yeah, I've had a lot of time to think about Nurse Rivers. And let me just give you a context and you can decide. 1930, 1940, 1950, black nurse, rural southern Alabama, working with white physicians from the government. And there's a power dynamic that's often overlooked. When the dynamic of nurse-physician, who's usually in charge? The dynamic of men and women, particularly in the 30s and 40s, who was in charge? Rural South, black, white, who was in charge? how in the world could Nurse Rivers do anything? And then to blame it on Nurse Rivers is unethical. And I'm not sure how many of the men got penicillin because of Nurse Rivers, because a lot of them did. So you just don't know. And what I've learned about ethicists is that ethicists don't answer questions, they question answers.
Just absolutely fabulous. Let's have another round of applause for just an excellent talk. You know, if you've met Mary Harper, and some of us have had the honor to have done so, your life is different before the moment you met Mary Harper, and then after you met Mary Harper. And I think, Dr. Warren, you're very similar. Your life is different after being in your presence, your wisdom, your word. So I thank you for that very much. And for the depth of your discussion and thinking about nursing as the most highly rated profession for trustworthiness, we'll have to change that. And I'm thinking of a couple of things, because nurses already start thinking, what are we supposed to do now? So Dr. Melkus is here in our audience. I don't know whether Susan Apold is. But they are our research and our IRB folks. And I'm wondering, when we have to do the IRB training, we have to train around what's often called the Tuskegee syphilis study. So maybe we should go into that training PowerPoint presentation and change the words to the U.S. Public Health Service study on syphilis at Tuskegee, and we could probably just go in and get the university to change those words if they're not changed already. So there's something like that that we can already do. And I refer you to Susan Reverby's work as well if you want to know more about Nurse Rivers. And Susan Reverby is an historian in health and nursing, and points to a lot of the power of the pen and authority and how Nurse Rivers was stuck, as you say, in that regard. So back to Estelle Osborne. So thank you for being here. We heard a lot about Nurse Osborne, and I thank you for that. And we're privileged at NYU to have had her as our first black faculty. And of course, as we know, she was the first black nurse to have a master's degree in the United States. And so she worked tirelessly to eliminate discrimination, as you can imagine, so being the only one, in the professional nursing organization in this country and society as a whole. And that legacy continues today. We have her portrait. When we moved to the new building, we spent some time thinking about where should her portrait be, and we had our committee look at that. And it's now in the gathering area where students gather, come in and out of classrooms, in our classroom area in the new building, right between the McGivern student suite and the leadership suite, but it's right where the students gather. And so they see her portrait and a description of her work daily, and we just hung that recently, and we're proud to have done so. So every year we present an award to one of our distinguished alumni or faculty, someone whose career embodies the true spirit of Estelle Osborne, and this year we're proud to honor Dr. Natalia Cineas, who's here with us today, of course. So we would like to invite you to join us as we open the screen and move to the next area for reception and to have the award ceremony. Thank you.